My name is Nico Misleh. I am a board certified family nurse practitioner. I personally am from the greater Cincinnati area and have been here my whole life. I graduated from the University of Cincinnati and predominantly have been around medicine almost my entire life. My grandfather on my mom's side is a retired physician. And funny enough, he had always told me never ever go into medicine. I was in pre-med at one point, and he kind of talked me out of it. And so I was in this state of duress and like, what am I supposed to do with my life? Anyways, long story short, I met a family friend of mine who was a nurse, and she said, "Oh, you should look into going to NP school. There's all these great ways in which you can kind of do medicine without having to take on a crazy amount of debt and crazy amount of schooling." So anyways, I kind of traversed through that. Pretty quickly, I recognized that I wanted to be a nurse practitioner and own my own clinic. What was not clear to me was how I was going to do that. I was really, really disillusioned with, the kind of conventional medical care model. I really hated my time in primary care because it was, as you can imagine and remember, so miserable seeing these people over and over again dealing with diabetes and strokes and heart attacks and cardiovascular disease stuff. So, I knew that anything I was going to do was going to be different. And so I really started getting into, at the time, it was really more colloquially termed integrative medicine. I think
Mhm.
more people probably hear that and think of functional medicine, which is kind of taken over at this point, more or less the same thing. So I was really lucky. I had some really amazing mentors locally in the Cincinnati area who kind of took me under their wing. And I spent most of my clinical hours in kind of like a functional or integrative medicine setting. And so that kind of really spurred this movement of, all right, I'm going to start my own business at some point. I'm going to start my own clinic, but I really, really want to become more than adequate at integrative and functional medicine.
Sure.
So I kind of got this opportunity at one point in time to practice functional medicine in believe it or not, a mental health and therapy group. So predominantly, these were nurse practitioners prescribing, psychotropic medications to your typical psychiatric patients, and they I kind of pitched to them this idea of, hey, it seems like in this area in particular, there's this kind of like weak spot where there's no functional medicine here. There's no integrative medicine here. It's always just psychotropics are kind of the only way in and out of this disease.
Sure.
So, anyways, they fortunately let me kind of do my thing. And what that looked like was I was in this horrible insurance model and I'm doing hour-long appointments with these patients and getting, 20, 30, 40 different lab markers off of these patients via blood work. And, it was very apparent that this was really exciting. I had a lot of patients improving very quickly. This is via supplements and hormone replacement therapy. And funny enough, I started becoming known for hormone replacement therapy in that community.
Hell yeah.
Predominantly, this was actually treating males and females. For men, it was mostly depression, anxiety, and PTSD, using primarily testosterone replacement therapy and oxytocin and different things like that. And then for my females, I was working with a lot of postpartum depression and premenstrual dysphoric disorder, which is a little bit lesser known pattern of basically what was considered to be a psychiatric disease, but is definitely more of a hormonal issue, if anything. So anyways, the word kind of got out that I was doing this. And very fortunately for me, I became very, very busy and I jumped quickly over to a cash model and started my own business from there. So, I kind of traversed into now what would be hormone replacement therapy predominantly for men and women. I still do quite a lot of integrative and functional medicine, but it's a little bit more of a background thing. As you know, Justin, I mean, hormone replacement therapy as a whole is so incredibly powerful and potent. It
Sure.
really ticks
Absolutely.
boxes for, I would say 90% of my patients' problems and symptoms and issues. So again, using that as kind of the forefront of what we are doing at our clinic has been really attractive. And I think the more that patients see clinics like mine and yours and many of our other colleagues, it just becomes apparent that hormone replacement therapy is kind of like this cornerstone, and it can't really be avoided. It's almost like a, all roads lead to Rome kind of thing. So, anyway, sorry, that's a long-winded introduction, but that's kind of
No, it's
me in a
awesome. So, what have you found to be one of the underpinnings or one of the underlying etiologies when it comes to people that let's say they do have a lot of psychiatric things? How does the hormone tie in? How does it benefit people who do have like the psychiatric diagnoses, so to speak?
Yeah, that's such a good question. I mean, obviously, this comes from a variety of different areas. Patients always ask me, it's almost like this chicken or the egg problem. What started all of this? Why are my hormones so low? Why is it that with certain psychiatric diseases we can find symptom resolution? And the answer is I'm not really sure all the time. We know now, it's very clear in the literature that much of these endocrine disrupting chemicals in our environment, be it plastics or certain types of toxins added to our foods and clothing and water and different things like that, can have massive effects in utero. So, a lot of us are literally born kind of behind the eight ball in a lot of ways,
Sucks.
which is depressing. But there are a lot of other things that compound across that. So, men with PTSD, there are many great minds out there who have looked at this well better and well more versed than I am, even who have noted that men with low testosterone levels, if they, let's say, go to a combat area, those men are like 3 times more likely to come back with PTSD. So not only is testosterone seen as like a treatment for PTSD, but it also appears to be protective against PTSD. So again, you can kind of see how it's very nuanced and convoluted there. For females in particular, I do think the environmental issues play a much more significant role.
Yeah.
Most of the environmental issues are estrogenic in nature. So these endocrine disrupting hormones, also called xenoestrogens,
Hmm.
they're quite literally mimicking estrogen. And we can see this across the spectrum for guys. And in fact, I've kind of coined this term, like, I don't know, androgen deficiency syndrome. It really mirrors PCOS. If you think about a lot of the females these days having issues with fertility, with moods, with their cycles at large, that mirrors very well with men in terms of weight gain, obesity, depression, and anxiety. It just kind of is a different, a slightly different pathology, but similar noise. So anyways, for the female patients in particular, we have found that using predominantly things like progesterone,
Hmm.
thyroid, which are potently anti-estrogenic in many ways. And again, not to say that estrogen is a bad thing, but rather the overabundance of estrogen is causing a lot of their issues. So let's say a female, for instance, with PMDD, this premenstrual dysphoric disorder, these patients come to me with pretty much acute psychosis once a month. The kind of week leading up to their period, where most women are experiencing what would be considered PMS, and maybe they have some irritability, difficulty sleeping, things of that nature. These women, it's like times 20, where they
Mm.
quite literally enter into a state of almost psychosis, rage, irritability, aggression. Some of them have suicidal and homicidal ideations and things of that nature. Those women, unfortunately, were just told, look, this is a psych illness. You've got, some sort of serotonin imbalance in your brain or something to that
Sure.
effect. And the only thing we can do for you is give you antidepressants or
Sure.
anti-anxiety medications to kind of quell that. Do those medications work? Not really at all in terms of the setting that these women are under. I would say it barely kind of, covers the flames of those symptoms. When these women come to me, what we're looking for predominantly is hormone imbalances. And what you'll always find in women with PMDD for the most part is very, very low progesterone levels. And the minute you start giving them progesterone, and let's just, for an example, a young female, otherwise relatively healthy, might take, anywhere between 100 and 200 milligrams of progesterone during her cycle. These women are taking, anywhere between 400 to 800
Mm.
milligrams of progesterone, and potentially even twice daily, just to, kind of recover from their low progesterone deficiencies. And it's amazing because quite literally these women will have a complete 180 in terms of their symptoms, and really it just they're PMDD kind of disappears. And so it's been an amazing journey watching a lot of these patients, go from kind of the conventional medicine approach, which is really just a sorry for kind of the shitty hand of cards and good luck with this antidepressant,
Yeah.
over to, hey, I can actually function and be a normal human being, and I'm taking something that inherently is A, natural, and B, really kind of good for me. So it's kind of like we get to have our cake and eat it too in a lot of ways.
Do you find the application or the form of administration of the progesterone actually plays a different role, or it has more efficacy than others? How do you typically approach what it would be the type they would need?
Yeah, so for females predominantly, I personally really like to use oral capsule compounded progesterone. Micronized compounded progesterone is fantastic, especially for patients with PMDD. One of the things that I find is that if you take it orally as a capsule, it has to go through this first pass, what we call it's a metabolization of progesterone in the liver. What a lot of medical practitioners might tell you is that, well, that's actually a negative thing. We don't want these medications to go through that first pass. We want it to be its active form and maintained. However, when progesterone is taken through the liver and metabolized, one of the things it metabolizes down to, so if you can think about progesterone as a molecule, the liver kind of cleaves it and breaks it up and
Hmm.
turns it into several other molecules. One of them, the most predominantly powerful one, is something called allopregnanolone.
Hmm. Hmm.
And allopregnanolone is predominantly where we get the positive mood benefits from progesterone. So allopregnanolone is a neurosteroid. It comes up to the central nervous system, specifically the brain, and it enhances something called GABA, which is, a lot of people call it like kind of the brake system, the brake
Hmm.
pads of the brain, where instead of excitatory, anxious, overwhelmed, we get calm, relaxed, stable moods. And so, again, you can kind of identify that for people with mental health issues, especially females around PMDD and even postpartum depression, we want to optimize for that allopregnanolone overload,
Sure.
so to speak, and pull that metabolite up in the brain so that they can, get a resolution of symptoms. You can get that still. You will get some of that with a sublingual, like a troche or something like that.
Sure.
Some women use creams. I do not find the creams to be very efficacious at all. But with a cream or a sublingual, you'll get very minuscule amounts of allopregnanolone in comparison to the oral progesterone.
Besides allopregnanolone, do you in having its neurosteroid type benefits? Do you ever use stuff like DHEA, which has also been shown to have CNS active benefits as well? Do you use things like that?
Totally, totally. So I'll tell you, I mean, a lot of these other kind of unknown compounds to, especially in the even conventional medicine, would recognize the benefits overwhelmingly of progesterone and testosterone to some degree.
Sure.
Things like DHEA, pregnenolone, oxytocin. We use a lot of these in our clinic for men and women alike. DHA is an incredible neurosteroid. And much like allopregnanolone, it kind of plays its role in two different ways. It's a sex hormone, and it's very similar to testosterone. It's an androgen. So we see very similar effects to testosterone via DHA supplementation, and which is great. But what a lot of people don't recognize is that we also get a ton of neurosteroidal benefits
Hmm.
from DHA. This is where we see a lot of the research going into, kind of as a CNS anti-inflammatory. So we
Hmm.
see a reduction in depression, a reduction in anxiety. We likely see a lot of benefit in things like dementia and Alzheimer's prevention, general immune system improvement at large. And again, the similar thing we would see with something like pregnenolone, which is making more of a splash these days. At least I'm seeing it a little bit more in the
Hmm.
research as another benefit to things like bipolar disorder, schizophrenia,
Hmm.
where and likely the reason we're seeing such benefit from things like pregnenolone is because of its metabolization down to allopregnanolone, which is not dissimilar from what we're getting with progesterone. So again, we got a lot of really cool things going on with some of these kind of outsider hormones. And again, we've I've heard you speak about this. I've heard many of the other docs and nurse practitioners speak on this, where, this is why we don't want to block some of these metabolites. So we think about estradiol from testosterone and dihydrotestosterone from testosterone. These are things we don't want to block. And similarly, it's the same reason we, would want to have some amount of metabolization of progesterone to allopregnanolone so that we can get all the benefits. Otherwise, why would we give these hormones if we don't get the extra benefits they bring?
Sure. So you're actually talking about like PMDD. I know for postpartum depression, there's a new drug coming on the market. It's brexanolone, which is essentially just a metabolite. It's a pregnant metabolite, but it's like $2,000 to $3,000 per IV treatment.
Right.
Why is medicine not just going towards the actual hormone deficiency instead of using these high dollar things? Why do you think that's happening?
That's such a great question, and that medicine is, just to be clear, it's unbelievable. When you're looking at randomized control trials using this medication called brexanolone, brexanolone is really just straight up allopregnanolone.
Hmm.
What they were able to do is more or less capture it as a molecule, probably add some sort of methyl group or something to it, and now it's a patented drug. Um, Pharmaceutical companies at large tend to do this, and I think we all understand the reason why. You can't really patent
Sure.
something that's nature. You can't patent vitamin C, you can't patent testosterone. It is what it is. So there's not a lot of money to be had, even though it provides a lot of symptom resolution. So a lot of big pharma companies will take the research that is coming out under, say, pregnenolone or allopregnanolone, identify that kind of the most helpful molecule. It's a very reductionistic way to, again, get to the root cause, more or less. But they'll take that molecule, they'll patent it, and they'll put it out as a very expensive medication,
Sure.
usually very difficult to even get a hold of, even as a practitioner or provider alike. And so, anyways, what we can get, in terms of symptom resolution with progesterone, high dose progesterone, to
Yeah.
get to the allopregnanolone, is just as effective, and I would even say probably more effective than
Hmm.
simply using one singular metabolite. This is the benefit of hormones. Hormones carry with them a pleiotropic effect,
Yeah.
meaning they
Yeah.
they are going to have effects across the body in multiple different ways, and in many ways we don't really truly understand, because of its ability to metabolize down to other
Sure.
byproducts and have similar responses and different responses, all the like.
Sure. And I think you're 100% right. Even like with like peptides, you can't patent it. So what do they want to do? They just say, oh, well, you can't purchase it. We're just going to drop the supply. Kind of sad that big pharma's kind of doing this like that, though.
It's terrible. A lot of my patients, I mean, it's always a question that comes up at some point inevitably, of like, I don't understand, why hasn't my doctor or my nurse practitioner told me about the benefits of testosterone or progesterone? Or why isn't it that, these medications are widely available or relatively inexpensive and things of that nature? And the answer is pretty clear. In the conventional system, I've heard multiple people call it the sick care model, and that's exactly what it is. I
Sure.
tell my patients, it's kind of a morbid thought, but the deal is, we want you sick, not so sick that you're dead, but sick enough to where you have to keep coming back for more. And our models are kind of the exact opposite. It's not to say that we don't get paid a healthy living, but it's also to say that the idea is you're investing in your health and you get much better over time,
Yeah.
versus kind of keeping you under wraps, keeping your health and wellness under wraps in order for us to make a living. I think
Sure.
that's kind of a gross way to conduct business and a gross way to do medicine.
Absolutely, man. It is kind of horrible. And if you think about, you just follow the lobby dollars, then you kind of see, yeah, you see where it's all going to, or where it's all coming from. Building on to talking about something like the hormones you're talking about, you can provide progesterone, then you get all the downstream metabolites. Whereas if you go straight to the intermediary, you're not getting that benefit. No. So do you ever do like blood testing for those intermediates, or do you typically just like treat based on the symptom, or are you treating it based on just the principal parent hormone? I'm kind of curious how you approach it from a laboratory approach.
Yeah, that's such a great question, man. When I was in my early stages of doing a lot of the hormone replacement therapy, I was very interested, just from a kind of my own personal research perspective on, looking at some of these metabolites, which you can do. And do we see a correlation with symptoms and symptom resolution? The answer was very clearly it's not all that.
Sure.
Meaning that, again, and I know you've kind of talked about this on your podcast a few times with other people, the markers are really just, if anything, a rough guideline in terms of, does this person have symptoms of whatever that might be: low testosterone, low progesterone, low allopregnanolone. The blood markers themselves are not inherently sensitive to that person's response, whether I'm giving them medicine,
Mm.
or whether we're trying to do a supplementation or some sort. So, I don't really, especially for the metabolites, most of these metabolites are, having intracrine effects, which I think you guys have talked about a lot. Dr. Jordan Grant is very keen on that kind of stuff. And so really, from my perspective, a lot of it is symptom resolution. And
Mm.
it sounds a little bit cut and dry, and it truly is in some ways, but I think it's also, to some degree, it's becoming a lost art in our side of the world. We transition so much over to everything has to have objective measurements,
Yeah.
which is great. And I'm a big fan of that. And this is why we check blood levels very regularly. But we also became beholden to those objective measures. And this is what you see in conventional medicine, where, oh, all my labs are normal according to my doc, but I feel terrible.
Yeah.
Um,
Yeah.
and, and so we have to be able to also position ourselves back to, well, look, the labs are the labs. They're numbers at the end of the day. Can they help guide treatment? Of course, but are they really the end all be all for me and my patients? Absolutely not. So things like dihydrotestosterone, allopregnanolone, again, the tests are very expensive in general, because they're so infrequently utilized. And the serum levels, it's very clear in the research that even DHT, for example, dihydrotestosterone, it's very, very clear that serum levels of dihydrotestosterone really share very little relevance in terms of symptom resolution, or symptoms at large.
Gotcha. So the understanding premise is like you're not going to stick strictly to this. You're listening to the patient. You're in the trenches listening to them.
That's right. That's exactly it.
Excellent, excellent. I'm curious, like you're talking about oxytocin. What kind of applications would you have for that?
Yeah,
If you don't mind discussing.
oxytocin. Yeah, absolutely. Oxytocin is amazing. It's a very expensive hormone, and a
Hmm.
lot of that is probably just due to supply and demand, which is very little. But oxytocin is predominantly seen as a bonding hormone. A lot of people call it the love hormone. So it's very much secreted at specific times, directly after intercourse, for example. Mothers, when they're breastfeeding, will have a rush of
Hmm.
oxytocin. Anybody who's had that experience after intercourse, or maybe even breastfeeding, will know that feeling of love and closeness and openness. It's really an amazing effect. Where we see a lot of application for oxytocin, I've found especially, is for two parts: sexual wellness issues, where maybe men or women are having difficulties achieving orgasm,
Hmm.
or maybe they're having difficulty in that intimacy itself, bonding to their partners and things of that
God.
nature. A lot of these men and women tend to have histories of abuse, whether it be sexual, verbal, whatever. Many of these patients have things like PTSD, traumatic brain injury patients certainly fall into this category, where some of these patients just truly don't produce enough of it. We have seen this in the clinical literature trying to be utilized for autism. The results are kind of skewed. We see some literature saying it's fantastic. Other literature, it's still kind of who knows. I think a lot of that has to do with the dosing and the administration, frankly.
God.
So
Yeah.
oxytocin, for in a lot of the literature, it's given as a nasal spray. Um, you and I both know nasal sprays for hormones really don't produce adequate numbers, generally
Yeah.
speaking. However, sublingual oxytocin tends to work very well. There is subcutaneous oxytocin. I've never personally had access to that, but apparently that is the creme de la creme. So most of my patients use sublingual oxytocin. For things like sexual wellness, taking that, 30 minutes before intimacy or something to that effect has tremendous results. in terms of improving orgasm or allowing that person to achieve orgasm. And again, and kind of creating that tight, intimate bond. And then furthermore, for a lot of my patients, this is a really common one, say a male patient who perhaps is a first responder, especially police officers, or maybe they've come back from a combat area. A lot of these guys have really, really, really strong problems with entering into large crowds, for example,
Sure.
busy restaurants, even the grocery store. I've got some cops who just cannot handle going into a major grocery store on a Saturday. Um, I'll give them oxytocin and they just take it as needed, more or less. But man, they take it and they can just kind of cruise through life all of a sudden. It's like it's kind of just like renewing to them. And they all of a sudden, instead of feeling like fearful and maybe anxious around human beings, they feel more open and connected. So it's amazing. It's an incredible therapy.
I've never heard of that before. Using it for like public anxiety or like
It's
agoraphobia. I've never heard about that.
it's incredible for that stuff. Even patients. I mean, I'll use umbrella term social anxiety. Any
Sure.
patient who has any sense of that, and whether that's agoraphobic kind of response, maybe they're just a little bit more of an introvert and they just really struggle with speaking in groups and things of that nature. Using oxytocin can be extremely powerful. And what I've found is that a lot of these patients, once they start using it as needed kind of regularly, a lot of them will also condition themselves to
Sure.
feeling like as though they don't need to rely on the oxytocin anymore. Now all of a sudden they can kind of go out and about their business and feel like they can connect a little bit better.
What do you think is the underlying mechanism of action of how that helps people in those settings?
Oxytocin predominantly is anti-cortisol. And I have
Gotcha.
I have a very strong suspicion that its ability to acutely lower cortisol, and kind of raise what I would call the more anabolic androgenic hormones, um, kind of correlates to this. Patients feel a little bit more self-confident, a little bit more
Hmm.
self-aware. They feel a little bit more light. They tend to have less of this, kind of fearful tendencies where a lot of patients will notice with high cortisol levels, they feel very anxious.
Sure.
It also naturally tends to have an anti-estrogenic effect. And again, I don't mean to belittle estrogen because it's very
Sure.
important, but estrogen kind of plays off of cortisol. So as cortisol increases, it will kind of play on our cells on these what we call glucocorticoid receptors, which will stimulate estrogen production. Estrogen production will then lead to kind of a histamine response, and we'll have an increase in prostaglandins and cytokines. And so, really, we start seeing this wheel of inflammation start to occur. And very much so even in the central nervous system. So things like oxytocin, even melatonin, for example, are both of those are potently anti-cortisol and therefore pro anabolic and kind of anti-stress hormones, let's call it. So it appears that is predominantly one of the stronger mechanisms of action that oxytocin is playing on outside of some of its kind of specialized effects on the central nervous system itself.
Gotcha. Gotcha. Learn something new every day, man. I love it. So I saw you're reading up on melatonin recently, and I'm not gonna lie, I love melatonin. What are your thoughts? Or do you have any applications for it, or have you started integrating, or what's your
Yeah,
experience?
I love melatonin, man. I mean, I personally take it. I've taken it for many years. One of the things that's very obvious to a lot of people is that melatonin can help with sleep.
Sure.
But from what I've been reading in terms of even the literature and things of that nature, melatonin goes way beyond sleep. Sleep being almost like kind of this cherry on top of what melatonin does. Melatonin is at large arguably the most powerful antioxidant that the body produces. So a lot of people have probably heard of glutathione, which is gaining some
Hmm.
popularity. A very, very potent antioxidant. Melatonin is probably even more so, and melatonin is produced in every single cell in the body. And it has very potent effects on protecting the mitochondria. So not only preserving and conserving the mitochondria, but also increasing the output of energy. It drastically improves gut health. For whatever reason, we don't have very clear understanding of this. The microbiome has a kind of what we call a swarming effect when melatonin is ingested. Meaning they'll actually kind of be attracted to that melatonin. And likely it's because they utilize melatonin much like we do in terms of, cellular protection and mitochondrial protection. Melatonin outside of even that, we're seeing a ton of anti-aging effects, a lot of anti-cancer effects. And again,
Mm.
all of that is likely in part of its ability to reduce, reactive oxidative species or ROS and preserve that mitochondria. The more we preserve the mitochondria and maintain energy output, the more likely we are to hold a really, really tight structure of, say, the localized cell or tissues or what have you, and
Yeah,
therefore protect us against cancers, which is really just a, kind of a de-evolution of the cells locally.
sure, sure. Besides melatonin, have you found any other medications, nutraceuticals, supplements, things that you've used off label for like the anti-inflammatory, anti-cancer properties?
Yeah, there's some really interesting things going on with aspirin. One of my
Yeah.
favorite researchers and kind of controversial characters out there, his name was Dr. Ray Peat. He just passed fairly
Hmm.
recently. Dr. Raymond Peat was a biologist, a PhD biologist, and he was one of the guys, back in the 1960s, kind of preaching the benefits of hormone replacement therapy. The detrimental effects of estrogen on our society and cortisol and all these sorts of things. And aspirin was one of these compounds that he found to be very, very efficacious in this kind of setting of toxicity and environmental issues. Aspirin, in many ways, is obviously an anti-inflammatory. It's an NSAID, non-steroidal anti-inflammatory, kind of like ibuprofen. Aspirin is predominantly a salicylic acid product, and what that essentially does, outside of reducing things like cytokines and prostaglandins and cox and lox and all these different really inflammatory byproducts of the cell, aspirin tends to promote very, very healthy oxidative phosphorylation in the cell. And for anybody who's wondering what the hell I'm talking about, our cells basically, in order to produce energy, goes through a function of oxidative phosphorylation. This is, think of it this way. My car runs on gasoline. I want the purest, most efficient gasoline that I can possibly get into that engine so that A, it produces energy out, and B, it doesn't create a bunch of junk inside my
Yeah.
engine. So if we think about things like, I don't know, you go to some third world country and you get some gasoline in your engine, that might not be very pure. Furthermore, if that engine starts to really degenerate because of all these nasty byproducts building up in it, in the cell, so to speak, it'll kind of switch over to what we think of like a very primordial energy output mechanism. And this is kind of the Warburg effect, which is coined after Dr. Otto Warburg, who kind of discovered that cancer evolves from this inability of the cell to use oxidative phosphorylation and instead moves over to like almost like a glycolysis response, which is very, 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 very deleterious. Because what we're essentially doing is saying the cell doesn't have enough energy. Now we have to start, instead of going from oxygen to CO2, now we're going to go from like fatty acid peroxidization. We're going to increase all these really nasty reactive oxidative species and really end up with a proliferation in cell growth, which is exactly what we don't want in terms of cancer. And we'll have this inability to kind of go back to this kind of oxidative phosphorylation. So long story short, aspirin as a compound tends to protect and preserve the cell's ability to maintain oxidative phosphorylation. So patients with metabolic dysfunction, your type 2 diabetics, your patients with obesity, patients with things like polycystic ovarian syndrome or PCOS can benefit quite a lot from aspirin. And aspirin is not nearly as dangerous as people think. It's actually quite safe to take, even in dosages as high as 600 to 1,000 milligrams a day. And that is predominantly where we see a lot of the benefits. So I don't personally take aspirin every day, but it is something I will take maybe once or twice a week just for its positive effects on maintaining like glucose metabolism and ultimately that kind of oxidative phosphorylation.
Yeah, and it's if I'm mistaken, it's an irreversible COX inhibitor. So if you just take it once, it's going to last at least 72 hours minimally, if I'm not mistaken.
Yeah, perfectly said. That's exactly right. So that is exactly why this is not something that has to be taken every single day. And even in the clinical literature, we see a lot of really potent anti-cancer benefits from long-term aspirin use. Even as much as a baby aspirin, we tend to see greater longevity and anti-cancer. So that's exactly right. If you're an otherwise relatively healthy person, taking an aspirin every now and then is, I think, quite healthy for you.
Excellent, excellent. So besides aspirin, have you heard of anything else? Like, I know some people do like metformin, some people do like rapamycin, some people do an NAD. Is there anything else that that's emerging?
Yeah, amazing, man. So I'll tell you, NAD is amazing. And I know you and I have actually talked about this in the past. NAD is incredible in terms of, again, maintaining a healthy cellular energy output. That's kind of the name of the game always. NAD is best done as an injectable. I personally use subcutaneous. I think you do too. I've seen it IV and IM. You can do it that way. It's kind of unnecessary. Subcutaneous is way less ouch and very efficacious. In most of the research, we can get very, very, very healthy levels of NAD simply from ingesting niacin or niacinamide, which is vitamin B3, nicotinic acid, or some sort of derivative. Most of the time, these medications are very much underdosed. We're typically looking at least 500 to 1,000 milligrams of niacin or niacinamide per day, but that will completely restore your NAD. And this is pennies on the dollar. So I predominantly use subcutaneous NAD for like very acute illnesses, for example, that's just gonna kind of wipe my NAD out completely. So the flu and colds and different things like that, I'll kind of use it as needed. But usually I'm taking niacinamide. Again, at about 500 to 1,000 milligrams, niacinamide will absolutely restore and maintain NAD levels if you're otherwise healthy. Metformin, I have a really strong beef with. Metformin has been seen to be an anti-aging drug. I think the literature is sparse, in my opinion, on that. I think that it's a little bit convoluted. Metformin is predominantly going to affect your metabolism, and ultimately it is very harmful to the mitochondria. So I'm not a big fan of using metformin. I'd much, much, much rather shift over towards something like every now and then use aspirin and NAD to maintain mitochondrial function, which is ultimately going to help me avoid metabolic dysfunction.
Sure, sure. And that's actually an excellent segue because that's one topic I want to talk about was metabolic dysfunction. So what do you think in our society is like, honestly, one of the biggest underpinnings, one of the biggest causes of why there's so much metabolic dysfunction? And it's becoming more prominent worldwide. We're seeing more literature showing that not just in developed countries, other countries too, more and more men, women are having metabolic dysfunction or having lower and lower and lower hormones. So I mean, what the hell is going on, man?
Yeah, I mean, I think again, in terms of the literature, I think it's very, very clear that the endocrine disrupting chemicals tend to be the most ubiquitous reason for why. So anything that's plastic. I mean, quite literally anything, whether that's a plastic water bottle. I mean, think of all the foods that you go to the store and you buy peppers that are wrapped in plastic. You buy bottled ketchup, which is in plastic. You're drinking out of a water bottle that's plastic. Our freaking clothing is made out of plastic half the time, and like nylon and spandex and different things. So all of those, I mean, as stupid as it sounds, I mean, it sounds like woo-woo nonsense, but in the clinical literature, it is very, very clear that these endocrine disrupting hormones are absolutely detrimental to our hormonal health. There's also on kind of the diet side of the equation, obviously there's no reason not to believe that our genetically modified foods are wholly industrialized and overprocessed foods are totally destroying us. Again, I'll mention Dr. Ray Peat, who's really a hero of mine. He was again kind of speaking about this again back in the 50s and 60s. And he really noticed one of the things that seems to be, again, predominantly across the globe in terms of food product, even again, back in the 60s, where a lot of our foods were still relatively safe to eat. He noted that polyunsaturated fatty acids or PUFAs were very, 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 very detrimental to mitochondrial health and cellular health. And I see this quite a bit on Instagram and TikTok now. A lot of health influencers are kind of discussing PUFAs and polyunsaturated fatty acids. And really the idea is that these polyunsaturated fatty acids, which would be predominantly high in things like corn oil, vegetable oil, sesame oil, rapeseed oil, any of these oils that are tossed in our chips and crackers, anything that you're eating deep fried, basically anything that's shelf stable is going to have some of these oils in it. These oils essentially are going to destroy our cellular structure. They seem to have an effect on the phospholipid bilayer, where these polyunsaturated fatty acids are not chemically strong enough to hold the bond. And even internally on the cell, we're going to start seeing greater, because of this kind of poor structure, we're going to start seeing more fatty acid oxidation, which is going to, again, destroy our mitochondrial health. So he was a big proponent of, hey, we have to find ways to avoid polyunsaturated fatty acids. And again, every single country that you can think of, that, like, we think of these tribes in Africa and in Australia, who were, Aboriginal tribes. They were eating very, very pure, clean diets that they've been eating for thousands of years. One of the first things that really comes in to these tribes from the outside world is typically oils, for cooking and things of that nature. And very quickly we start seeing a huge increase in metabolic dysfunction. And again, a lot of people assume that it's too much sugar. Sugar was kind of the devil for a while, and then it was fat. There's too much fat. It's neither of those issues. It's predominantly polyunsaturated fatty acids, which were not in any way, shape, or form in an abundance at all in people's diets, relatively speaking, up until the last probably 100 years or so.
Yeah. It sounds like one of the big things that you keep resonating is mitochondrial health, cellular health. What are some things we can do, just for the average person, what are some things they can do to help optimize their cellular function?
Yeah, there's no question that, if we're playing the game of the root of all health issues, it seems to be very apparent that mitochondrial health is the key. And the reason being is because energy supports both structure and function. And this is where modern medicine has kind of gone away, from kind of this viewpoint. In order to improve mitochondrial health, obviously maintaining hormonal health is key. There is such a thing as entropy. We're all going to get older. We're all going to slowly lose those hormones. This is hormone replacement therapy and testosterone replacement therapy can be incredibly beneficial. Outside of that, I mean, all the kind of health and diet trends that we're seeing becoming more popular, which is fantastic. Eating whole foods, eating foods that are predominantly organic, ensuring that you are finding ways to detox in some way, shape, or form. And this doesn't have to be gimmicky stuff. Sauna is clearly by far the most effective thing that you can do in terms of detoxification. It's expensive, but if I've talked to a few of my patients, I've said, look, if I could put sauna in a capsule and give it to you and show you the benefits of sauna, you would pay any amount of money to get that capsule. Sauna is reducing like all-cause mortality by like over 50% or something. I mean, it's just insane how effective sauna is. And again, they're pretty available in local gym plexes, and you can get one for yourself at home for a reasonable price these days. So that's a really good one. I joke, but I mean this quite kind of seriously, spending time with loved ones, giving people hugs, shaking people's hands, being in the same room as another person. It's amazing how much that will allow us to lower our stress hormones, allow us to really connect. And that's amazing, in terms of your immune system and cellular health. Outside of that, really, again, going back to diet, I see a lot of things that are kind of, I think there's this game that we play where, if I'm in pain, it's a good thing and I should do more of that thing. And I see that kind of go a little too extreme with things like cold plunges, long-term fasting. It's not to say those things don't have benefit, much like exercise, but anybody would tell you, and you know this from your experience in the world of exercise, you cannot exercise for 12 hours a day and become healthier. Eventually, your body's just going to burn out. There's only so much that you can do. But for some reason, in the modern world, people think the more pain, more gain is kind of the goal. It's not. It's a little bit of stressor and a little bit of recovery, and it always has to go in that kind of
Mhm.
wavelength. What I see people do is tend to just go more, more cold plunge, more fasting, longer runs, heavier weights. And what they're really doing is just ultimately damaging a lot of their mitochondrial function versus improving it by just adding a little stressor here and there.
Gotcha. Sounds almost like, you know, if you want to build muscle, you work out, you rest, you work out, you rest, you give it, like you said, just a small bolus of an acute stress response, and then learn to adapt to that. But yeah,
Right.
I mean, I completely hear what you're saying, man. There's so many people that come to us and they're just trying to they're trying to out biohack all the bullshit that they're doing. They eat like crap. I mean, they drink, they smoke, but they're like, well, hell, I got a red light in my bed and cold plunge 5 times a day. Dude, I totally get it. You can't out biohack a shitty lifestyle. Um, any closing things you got for us, man? Like any piece of advice? Which you got, man? This your stage is yours.
Honestly, I appreciate it, man. It's been such a pleasure. A lot of people don't know this. Justin and I met, maybe a little over a year ago now, or maybe less than that even. But anyways, it's been so cool to be able to connect with people like yourself. I'm always a big fan of showing my patients, hey, you got to check out Justin's newest video on this, that, or the other, because you put out such great content and it's very,
Thank
very
you.
digestible. So I really appreciate even you just giving me the time of day. I'm again very, very, very encouraging of the fact that the more people like yourself and hopefully myself and our other colleagues out there are getting into this world of preventative medicine, anti-aging. I mean, really, that's what we're doing. We can call ourselves hormone clinics or whatever we want, but at the bottom, it's really a means of helping people get to a better state of health and educating them against some of the nonsense that has been espoused for decades. So, thank you.
Yeah, well, I appreciate you, man. Thanks for joining us today. How can people reach out to you?
Yeah,
Get your
absolutely.
information.
Thank you. Yeah. So my clinic is, again, we're located in Cincinnati, Ohio. I serve patients in both Ohio and the state of Kentucky. My clinic is the Apollo Health Optimization. You can visit apollohealthop.com if you want to check out the website. You'll see our Instagram handle on there, which is Apollo Health Optimization. You can personally follow me if you want on Instagram. I'm at 9 for Nico on Instagram. I'm on Facebook and all that kind of stuff. So anybody, practitioner, patient alike, feel free to reach out. Always happy to discuss topics with y'all.
Hell yeah, man. And I'll be sure to share it with you, man. Thanks for
Thank
joining
you,
us
brother.
today. Hey,
Thank you,
right on.
Justin. Appreciate it, man.